everybody, and I'd like to start with thanking the organizers for the opportunity to present. Today, the topic I was given was barriers to kidney transplantation. So these are my disclosures, nothing particularly pertinent to today's talk. So as we all know, end-stage renal disease prevalence is on the rise. It's been on a linear increase and a fairly rapid increase over the last 20 years. And the cost of the end-stage kidney disease program to Medicare has also been on a rising fairly rapidly, where the total budget for end-stage kidney disease has increased from 18 billion to 37 billion. So that's more than a doubling of that budget over a 15-year period. And with the end-stage kidney disease population accounting for only 1% of the Medicare population, we consume approximately 7.5% of the budget. So we are an expensive part of the Medicare program. And despite the amount of money that gets spent on end-stage kidney disease, outcomes for end-stage kidney disease in general has been really dismal and hasn't really budged. So for patients with end-stage kidney disease who remain on dialysis, 5-year survival rates are marginally better than what we see for neurologic cancers and worse than what we see for GI cancers. So not a good place to be. And transplant is clearly the preferred treatment option for this patient population. So as you can see here in the group with the dark blue bars, that is the patients who have end-stage kidney disease and are on dialysis, their mortality rate is many-fold higher than that of the general Medicare population when matched by age. The general Medicare population here being represented by the orange bars. Now, however, the minute you give these patients a transplant, you can see that the mortality rate across all the age groups drops dramatically, almost to the point where it starts to approximate that of the general Medicare population. So that's a pretty impressive improvement in patient outcomes. What's more impressive is that unlike most parts of medicine, when you increase survival and you provide a modality that is associated with significantly improved outcomes, we're not increasing costs. In fact, transplant is by far the cheapest treatment option for end-stage kidney disease, making it a really cost-effective and attractive treatment for these patients. Yet despite that, despite the cost effectiveness and despite the dramatic survival advantage that transplantation provides, the number of transplants being performed annually in the United States has essentially stayed relatively flat for well over a decade. So starting in the mid-2000s through as recently as 2015-16, it was relatively flat. We are now starting to see a small uptick in deceased donor kidney transplantation. And unfortunately, living donor transplantation has stayed relatively flat and is perhaps lower than its peak earlier this decade. And what that means is that, that while we have transplantation, while we know it works, and while our transplantation rates have not been great, we also are now discovering that the majority of incident ESRD patients are never waitlisted. So among the 120 odd incident ESRD patients annually, nearly 100,000 patients in 2016 were never waitlisted, suggesting that we have a problem where we're not even offering these treatment options to our patients. So how do we know that? So in 2005, when Medicare decided they wanted to change the way the 2728 form was designed, they introduced this very simple question: has the patient been informed of kidney transplant options? It's a yes/no question. It's a good time to introduce the idea of kidney transplant. You're starting somebody on dialysis. We should be doing modality counseling. We should be talking about treatment options. And yet it appears that we aren't doing this at a point in time. So much so that there's a second question right next to it, which is, which unfortunately negates the benefit of the first question. It's this get out of jail free card, which says, if the patient's not informed of their transplant options, please check all those that apply. I can't think of a good reason, even if the patient's medically unfit, for not at least talking about kidney transplant with our patients. And as a result, when you look at the adjusted odds of being reported as not having been assessed for transplant, as in we as clinicians fail to even evaluate these patients as a potential candidate for transplant. We haven't actually talked to them about their transplant choices and opportunities. You can see patients who are on public insurance plans, Medicare and Medicaid, are at significant disadvantage compared to their peers on private insurance. The same thing for racial minorities, significant disadvantage compared to the average white person. Significantly, that's also true of patients who don't have prior care, from a nephrologist before they start dialysis. So the absence of nephrology care prior to dialysis significantly disadvantages these individuals in terms of being given the opportunity to discuss transplant as a treatment choice. And this isn't just in the year when they get transplant, when they start dialysis. This disparity continues out each year as we move out from when they start dialysis to going forward. So it's not even this idea that there's a lot going on in the first year, that there are complications, that people are crashing onto dialysis, all of which may be true. But years 2, 3, 4, when people are much, much more stable, and it's clear at that point that these are individuals who are going to be on dialysis long-term and therefore would benefit from potentially at least discussing transplantation as a treatment choice, it's not being offered to them in this manner where the disparities appear to just continue to grow year on year. This is particularly appalling when you look at how this is impacted based on dialysis unit ownership. So clearly, individuals who are receiving dialysis at for-profit facilities have a significant disadvantage compared to those of their peers who are at non-profit facilities. They are less likely to be placed on a deceased donor waiting list, which likely reflects lower referral rates. Worse still, even among the people who successfully have managed to get on a transplant wait list, individuals at a for-profit dialysis facility are less likely to receive a living donor kidney transplant or a deceased donor kidney transplant, right? Suggesting that the dialysis units themselves are not doing anything to support what is in their patient's best interest, which is getting a transplant. Now, it's not just the dialysis units, right? And not just the patients. And it's not surprising that frequently clinicians and nephrologists are wondering why the onus should be on them to talk about transplantation. And the rationale is very simple. Patients depend on their clinical teams to get information about their treatment modality choices. There should be no surprise about that. So when we surveyed hundreds of patients across dialysis facilities, and people with CKD and people who had transplants across the country, and we said, how do you get your information about transplant? Who are you turning towards? Yes, there's a small proportion of people that are turning towards the web, but the vast majority of patients are looking for this information from their clinical nephrologists and from the social workers and other clinicians in the dialysis units. And so the onus is on us to make sure that our patients are adequately informed, well educated about their treatment options if we're going to get it. So in short, barrier one is us as clinicians. Now, if we're going to refer somebody for a transplant, we have to have some understanding of the kidney allocation system. So the new allocation system, which is not so new anymore since it was set up in 2014, had one key change, which was probably the most critical change, which is the calculation of allocation time for when your clock started, so to speak, was changed from the time of waitlisting to your dialysis initiation. This was done primarily because we recognized that there were large racial disparities and socioeconomic disparities in terms of when patients were being referred for evaluation and waitlisting. So now the way the system works is regardless of when you get waitlisted, the clock resets to start on the day that you started dialysis with the understanding that that's when the patients actually needed a transplant. So that's been very effective at eliminating some racial disparities. It has been very effective at lowering socioeconomic disparities, but it has had some other unintended consequences that we'll get to. This is the first one. Because we know that you can backdate when allocation time starts, the sense of urgency that we as nephrologists feel for listing patients appears to have decreased. And as a result of that, the proportion of patients with end-stage renal disease that are currently on the wait list has been declining very rapidly since the introduction of CAS. So from a peak of 17.5% of prevalent patients, which I will say is still a dismally low number, we have started to drop dramatically to a point where we've dropped below where we were in 2000. So we have essentially in the last 5 years wiped out the gains from the preceding 15. Much of this is in the inactive waiting list, but it is also, you can see a significant drop even in the active wait list. This is particularly concerning when you couple it with the fact that dialysis facilities, particularly those with low waitlist rates, have low awareness. So this is a survey that we did of over 600 dialysis units across the United States with racial disparity and low waitlisting, right? And what we found essentially was that less than 50% of in these dialysis units had dialysis staff that was aware of the kidney allocation system. So if you as a clinician or the dialysis unit staff at the bedside does not have the ability to describe or discuss the kidney allocation system effectively to their patients and answer their questions, it's no surprise that patients feel overwhelmed and unable to figure out how to navigate the system to get on the transplant wait list. This is made worse by transplant center behaviors, where for many years they were assessed on transplant post-transplant outcomes. And so that focus on post-transplant outcomes has led to increasing selectivity at the transplant center. And what that has translated into is decreasing mortality rates on the wait list, and increased number of patients being removed from the wait list because they're deemed ineligible. This has also had an impact on preemptive listing. So just as a refresher, preemptive listing is listing patients on the wait list before they start dialysis. So patients are eligible to be added to the transplant wait list in the United States once their kidney function drops below 20. So if your GFR is below 20 mils per minute, clearly this is somebody who is going to progress eventually to end-stage kidney disease and ought to be on the wait list. And yet there is a small number of patients who actually take advantage of this. And that number appears to have hit a plateau since the introduction of CAS. Preemptive listing has the advantage of creating the opportunity for preemptive transplantation, which is clearly the ideal outcome for somebody with progressive kidney disease because it allows them to avoid dialysis completely, and that avoidance of dialysis is associated with the best post-transplant outcomes. And preemptive transplantation has increased after CAS, but it has increased in a manner where the disparities are starting to increase. So those individuals with private insurance have always had an advantage, and now that advantage appears to have expanded. Racial minorities were always at a disadvantage, and that disadvantage appears to have increased. But CAS was not all bad. CAS has had a lot of its intended effects have come true. So as an example, the racial disparity for people who are on the wait list getting a transplant has essentially been eliminated, right? This was a primary goal of the changes in the kidney allocation system in 2014, and these have clearly been met. However, what I'd like to point out is these are elimination of disparities once somebody gets on the wait list. The disparities to get on the wait list continue, and it's our responsibility as clinical nephrologists and nephrologists taking care of patients in dialysis units to correct that. So this is an example of just how widespread racial disparities in waitlisting are. So these are, each of these dots on this map of the United States represents a dialysis facility in the country. The blue dots are facilities that do not have a racial disparity in waitlisting, whereas the red triangles are facilities that have a racial disparities. Now, it doesn't really matter where these centers are or which centers they are. The point here, though, is the fact that it's widespread. There isn't any one part of the country that necessarily has been better or worse than another in terms of these racial disparities, but racial disparities are widespread, and it's important or imperative that we start to address them. Now, getting a transplant is not a simple process. It's a multi-step process, starting from when individuals who are on dialysis, so we have well over 500,000 patients now who have end-stage kidney disease on dialysis. They need to be educated about their options. They need to be referred, if appropriate, undergo a complex multi-step evaluation process at the transplant center before they're deemed a candidate for transplantation, at which point they then get waitlisted. And once on the wait list, there is waiting for a kidney offer to come by so that you can get a transplant. And yet, while we have this multi-step process, we have literally no national data about what happens between starting dialysis and getting transplanted, or at least getting on the wait list. We don't know where the attrition is. We don't know the extent of the attrition. And that has led to a real challenge because from a policy perspective, without data, it's hard to make informed choices. And it's notable that the current focus of quality measures for many years has been on transplant outcomes rather than steps to transplant. But I will add that that is likely to change in the coming few months to years. Now, disparities where there is data, either in single center or small multi-center studies, appear to exist at every step of the process. So as an example, fewer racial minorities start an evaluation after being referred. There's approximately the same number finish their evaluation. But again, fewer minorities are waitlisted, and among the people who are waitlisted, fewer minorities end up getting a transplant, right? So there is a clear disadvantage at every step of the process, resulting in that attrition process that we're seeing. Not only that, the number of days needed for completion at each one of the steps is significantly higher for racial minorities. This is also true of those individuals from lower socioeconomic groups. And this is largely perhaps related to their understanding of the benefit of kidney transplantation and the value of getting through these steps quickly. So this is a single center study from Rachel Patzer's group at Emory that looked at an educational intervention, as you can see, time from start of evaluation to completion and getting put on the wait list changed quite dramatically by just providing an educational intervention, right, of educating patients of the benefit of kidney transplantation and why they ought to get on the wait list. Not that hard to do, and something that we ought to be doing in the dialysis unit itself. The impact of the educational intervention was seen across all groups. So both racial minorities and whites both saw an improvement in completion rates. Those individuals with public insurance and private insurance all saw a dramatic increase in the evaluation completion rates. It didn't matter what the individual's education level was. Even those people who had finished college benefited from the education. And of course, the largest benefit was in those individuals who, with residential zip codes in poor neighborhoods. Now, it's important to remember that when a patient is looking for a transplant center, so once we've educated them as to what the benefits of transplant are, and they agree that what they ought to be doing is trying to get waitlisted, the single factor that they care most about is time on the wait list. So this is a national survey that looked at both chronic kidney disease patients and transplant patients to try to understand how do people want to make their choices and how do they make choices about where to be listed. And the bottom line is this: even for those patients who have already received a transplant, when they look back, they determine the primary determinant of how they should pick a transplant center is which center is going to give them the shortest time on the wait list. And that is particularly insightful. That's particularly insightful because of this. When you look at transplant centers and you are focused on post-transplant outcomes, you'll notice that the absolute difference in survival benefit at 5, 6, 7 years between the 3 tiers of transplant centers, those that perform as expected, better than expected, and worse than expected, all have a dramatic survival advantage to remaining on dialysis. So what happens post-transplant on average at a transplant center is almost less relevant. And this is consistent with the fact that we know that the single biggest contributor to long-term survival for patients with end-stage kidney disease is how quickly they get a transplant. The quicker you get a transplant, the better your long-term survival. And we also know that there is wide variation in the probability of transplantation across the United States. So this is data from 2015. So patients who were listed in 2015 and followed for 3 years out to determine what the probability of transplantation was. This is adjusted for the factors that are within the allocation system. and therefore accounts for the patient characteristics of those people on the wait list at each of these individual centers. And what you'll find is essentially this. The probability of transplantation varies from 4% at a low end to 66%. That's a 16-fold variation across the United States for the probability of transplant, depending on which transplant center you get listed at. Now, one could argue, well, this is well known, and it is true. The geographic variation of kidney probability of transplantation is well accepted in the United States, or at least well known in the United States, and has frequently been attributed essentially to the variation in the underlying organ supply. Now, while there is some variation in the underlying organ supply, we don't believe that to be the entire story. So this is data from Kristen King's paper in JASN from earlier this year, which I think is a really compelling story. So the country is currently divided up into 58 donation service areas. And the way the kidney allocation system works is essentially this idea that kidneys are first allocated within the system, within this service area, before they're then allocated in the region and then the country. So transplant centers within a single donation service area technically have the identical organ supply, and therefore should give you the identical probability of getting transplanted, regardless of which center you go to. However, if you look at each of the 58 donation service areas, here represented by the horizontal lines, the colored horizontal lines in each of the UNOS regions. So the color of the line itself is representative of the UNOS region that they're in. And the diamonds on the line represent the individual transplant centers. So as you can see, for example, if you look at region 9, which is New York, and you look at the first horizontal line, that line represents a donation service area in New York City and its surrounding suburbs. There are 9 or 10 transplant centers in that donation service area, and the probability of transplantation being after having been listed at one of those centers varies from 5% to 36%. That's a 7-fold variation in your probability of being transplanted once you've gotten on the wait list. So not only should we help our patients get waitlisted, I think the onus is on us as clinicians and nephrologists taking care of these patients to help our patients identify centers where the probability of getting listed and transplanted is highest and direct them there. And that is how we're going to get transplant centers to sit up, pay more attention to our patients, and work more aggressively towards getting our patients transplanted. Now, I've spent a fair amount of time talking about deceased donor transplantation. I'm going to take a few minutes to talk very quickly about living donor transplantation and the fact that there is a challenge, and if we're going to improve our living donation rates, we must first recognize that there are disparities here and that we're doing worse than we were many years ago, and that this is a challenge that we need to address. So, for example, here, we're starting out by looking at the risk of, or the probabilities, essentially, the hazard ratio of getting a transplant based on race across time, starting from 1995. Now, if you look at white patients, you can see that there has been almost a doubling in the hazard ratio of getting a living donor kidney transplant in 2014 compared to 1995, right? So over a 20-year period, it looks like it has almost doubled. That increase among minorities is much, much smaller, as you can see. Right? So instead of us nearly doubling, we're seeing a 10 to 20% increase at most. Looking at it a different way, if you look at the ratio of Blacks, Hispanics, and Asians getting a living donor transplant compared to their white peers, there's a dramatic difference. Hispanics at 50%, and Blacks at a mere 25%. Underscoring the fact that we're also seeing large disparities in living donor transplantation that we need to start working towards and addressing. So in summary, I've shown you that kidney transplant provides the best outcomes for our patients, and that our patients clearly depend on us as their nephrologist and care team for information on transplantation and in that initial referral. And there's no better time to do it than when patients are being started on dialysis if they're not already referred. Getting a transplant is clearly a multi-step process, and there are significant disparities that exist at every step of the process. As clinicians, we need to advocate for our patients, or we need to refer them to centers that have the shortest wait times, because that is what is in our patients' best interests. And as a reminder, the single most important predictor of outcomes is not the quality of the center or the rating of the center. It is how quickly they get your patient a transplant. And I'll stop there and take any questions. Thank you.